Yeah, SWI? What?
Yeah, is it T2 style?
So this is a PD weighted sequence.
Okay.
And on a PD weighted sequence, please remember that the CSF is equal in signal intensity to the gray matter. So the vessels appear as a filling defect. And as I told you in the beginning also, PDs are out of fashion these days. But having said that, this is a PD weighted sequence. So PD, flare, and a T1. We'll just crack on with this differential because we had done this differential last time also. But the idea is here two different findings are there. First of all, there are abnormalities, bilateral symmetrical in the basal ganglia, which include, the globus, the putamen here, and the caudate, and then thalami. So two different findings are there. And in your book, there is a differential diagnosis. We did cover it last time also, but just wanted to show you a few more quick cases. Now, deep gray matter abnormalities. Look at this word, deep gray matter. So remember that basal ganglia is gray matter, thalamus is also gray matter. And but here, basically, what is meant is, in Chapman, what is meant here is basal ganglia. And you can see it can have vascular causes, and some of these are potential exam cases. Venous infarction is a very important exam case, which I have showed you previously. Global ischemia, or near drowning, etc., that can come in the exam. Neurodegenerative, forget about it for the 2B exam, luckily. Toxins are very important. So they will be non-specific findings, but carbon monoxide, methanol, cyanide. I've also seen it with what we call, antifreeze, and then metabolic disorders. So metabolic disorders can be inherited. Nobody is going to ask you all of this pediatric world in 2B exam. Wilson's disease should be in your mind. The case which I have shown you is Wilson's disease. So in another differential diagnosis in your book is bilateral thalamic lesions. So you will see that there is a bit of overlap between the two. But there are some conditions in which both of these findings are seen together. You see carbon monoxide can cause this. Internal cerebral venous infarct can cause it. So this is important for the exam. This is important for the exam. And Wilson's disease can also be like that. So this is, just give me the findings, please. Candidate 1.
Okay, so it's unenhanced CT head, and there is low attenuation change in the deep grey matter involving the thalami and basal ganglia. It's bilateral and has a symmetrical distribution. I can't see any associated mass effect or hemorrhage. So this would be in keeping with a deep grey matter abnormality, and again may represent ischemic or metabolic abnormalities or poisoning.
Right. And poisoning should be up there. This was another case where you can see thalamic as well as the basal ganglia abnormality. I've got quite a few in my collection. This is another one in which this is, if you see carefully, there is a bit of white matter changes also. This was methanol toxicity. This is again methanol toxicity on a CT scan. And this is carbon monoxide poisoning. You can see in this case, there is abnormality in the basal ganglia and restricted diffusion also on DWI sequence. So the idea here is it's not specific. You cannot be specific in the exam. You can just discuss the differential diagnosis. If thalamus is also involved, then you know that you have to go into this one and consider the ones which are given in your book in which both of them can go together, as I have pointed out. Okay, over to you. 20-year-old female.
Okay, so we have selected sagittal and axial images of the brain in T1 and FLAIR. So there's abnormal foci of high FLAIR signal around the septocallosal region of the brain and juxtacortical areas of the brain as well. They appear to be different sizes and different shapes. I can also see one in the right or bilaterally in the medulla oblongata on the image on the left. Having a look, there's also some subcortical white matter changes. So findings would be in keeping with a white matter disease such as multiple sclerosis. I would correlate with the history. I'd also look closer at the eyes to see if there's any changes associated with optic neuritis and refer to the McDonald's criteria.
So, please continue.
And recommend post-contrast imaging to see if there's any enhancement of these lesions as well.
Okay, let me give you a hypothetical scenario. The optic nerves are normal in this case. On post-contrast, there is no enhancement. The patient has neurological symptoms, and this is the first presentation. What do you think is your diagnosis? What is your differential?
So I think my first diagnosis would be multiple sclerosis, given the distribution, because I can see septocallosal changes, Dawson's finger, subcortical white matter changes. I'd like to know if without a previous imaging, we don't know if there's any new lesions, and we don't know if any of them are enhancing to further characterize if they're lesions of different time and space. But I think my primary diagnosis would be MS for this patient.
And what is your differential?
I think I don't really have any for this distribution. It doesn't look like other white matter diseases like PRES or ADAM because of the distribution. ADAM, I don't have any other differentials for it in this pattern.
Okay, fine. But now we will come back to this. This is a differential diagnosis which is from previous edition of Chapman. So I'll build on this and we will go to the present edition then. So according to this differential diagnosis, the differential diagnosis of MS includes, vascular. So some of them are normal, mimicking MS, like age-related lesions. What is the the relevant point, age-related lesions? Some people think that there is a formula, we call it 1/4. Some people think they should be taken as normal. After the age of 60, they really, 30% of the people, they will have a lot of white matter abnormalities, and we undercall them. And please also remember that MS is a disease of younger patients. It can happen in childhood also. And here comes the concept of small vessel ischemia. So small vessel ischemia can happen it is age related, and that is why they are more frequently seen after the age of 60. But demyelination, vasculitis, vitamin B12 deficiency, etc. So they do a lot of screening also, and they will always do perspective of to be remember connective tissue disorders like SLE. You should understand that what will be the difference between this patient and a patient of MS. Both will be young. Also, for your clinical practice particularly, and for your exam also, always remember migraine. It's not given in the differential, so add it in your mind. In migraine, what happens is that there will be quite usual subcortical, this will be subcortical, so that's different. Usually, subcortical white matter abnormalities. We will come back to the features of the plaques of demyelination in MS, but these are subcortical. So these two should always be in your mind. Otherwise, ADEM, which is acute disseminated encephalomyelitis, is in differential. Please remember the clinical difference between MS and ADEM is that MS is a multiphasic illness. Acute disseminated encephalomyelitis is a monophasic illness. Both of them can also involve the cord. But the lesions of ADEM are different than MS. So in the real world, you will always consider in your differential. Part of the differential is clinical, which we will learn. But please remember that radiologically speaking, there are differences, and these differences will be asked in the exam. So I'll show you cases highlighting the differences. Now, central pontine myelinolysis. Remember this word, central pontine myelinolysis. Now the teaching is don't use this word. Use osmotic myelinolysis. Why? Basically, this condition can also involve structures which is other than pons. And sometimes pons might not be involved, by the way. That can also happen. So I'll show you a case, and this has come in the exam, osmotic myelinolysis. So this is from your previous book. Now, the latest book has divided white matter lesions into 3 headings or subheadings: punctate lesions, confluent white matter lesions up to 20 millimeter in size, and then diffuse white matter lesions. So the differential diagnosis changes. But one thing which I want to highlight from this differential diagnosis, look here, punctate lesions, and MS is there. But you will see that ADEM as an acute disseminated encephalomyelitis is not in this subheading. On the other hand, it is in this, under this heading. You will see it here. So what does it tell you? That in ADEM, the lesions will be slightly bigger, actually, more confluent. Sometimes, they are even like this, diffuse. But in MS, the lesions are more punctate. So, coming back to the case which was well described, we can see a few features which are quite classical. So you have to remember the classical features for MS. What are the classical features? Corpus callosum, particularly the undersurface of corpus callosum involvement. So if you see, this is the corpus callosum, and you can see, let me change my mouse to arrows. So this is the undersurface of corpus callosum. also known as callososeptal interface. So classically in MS, there is involvement of this. In some of the earlier studies, the sensitivity, specificity in MS for this was more than 90% actually. Now, Dawson fingers, if you look carefully, look at this one, look at this one, look at this one. These plaques are oriented perpendicular to the corpus callosum. They are also beautifully seen on parasagittal sequences. So that is why, protocol-wise, in a patient of MS, we must do a sagittal flare sequence. And this is a potential viva question, because the examiner can ask you directly, or you can even say that I would like to see a sagittal sequence to see the corpus callosum. So undersurface of corpus callosum can be seen on a coronal also, but better seen here. And these Dawson fingers in parasagittal planes, better seen on parasagittal flare sequences. So basically the veins in this area are oriented perpendicular to the corpus callosum, and they say that MS is a perivenular disease. So these orientations are very important. Another fine touch is that you have to develop your vocabulary about white matter lesions and how will you describe them. So they can be periventricular when they are touching the ventricle. They can be in deep white matter here, and they can be in the subcortical white matter. So divide it like this. Another thing which is given in the literature, that the plaques of demyelination as in MS, they actually, at many of them, they can touch the ventricular surface. On the other hand, there might be a bit of 3 millimeter up to 3 millimeter distance of white matter abnormality of small vessel ischemia, for example. This part of anatomy is the middle cerebral peduncle. So this is the pons, this is the cerebellum, and the connection between these two structures is known as middle cerebral peduncle. And some of the studies initially told us that there is high specificity if plaques are present here. This is the superior cerebral peduncle, which is the connection between the cerebellum and the medulla. And again, some of the studies have told us that there is high specificity if there are plaques there. At times you will see them on axial sequence also. So these are the features for which was correctly pointed out that this goes in favor of MS. So you should know that what are the features in favor and what are the features which are not in favor of other conditions which you want to discuss in differential diagnosis. So just a recap of the features. This is another case, and just to highlight the undersurface of corpus callosum. So even if there is not undersurface and involvement of the corpus callosum itself, just call it. Then superior cerebral peduncle. So here you are. This is the superior cerebral peduncle. Here you are. Here you are. And of course, this is the callososeptal interface. Now comes the role of contrast. It was correctly pointed out that contrast, I will use contrast to say, because I told you that hypothetically in the case which I showed you, there was no enhancement. But now there can be enhancement in active plaques of MS. Our criteria is there should be enhancement. Now, if there is enhancement, we call it active plaque of MS. And it can be, the enhancement can be complete ring enhancement. It can be what we call horseshoe enhancement, like this. Horseshoe enhancement is a very good feature which can discriminate a tumor versus MS, particularly tumefactive MS, which is an exam case I'll show you. And then there can be another enhancement which is known as nodular type enhancement. So there can be, if you see here, this is nodular. So nodular enhancement, ring enhancement, and horseshoe shape enhancement. Then comes the role of diffusion weighted sequence. So please remember that active plaques of MS can show restricted diffusion. And usually, initially, it will be bright on DWI and low on ADC map, but within 2-3 days, it might change. The ADC might become iso-intense to the parenchyma. Look here, DWI and central portion is low on ADC. And this comes a pitfall because I have seen people reporting and calling, because this is restricted diffusion, calling it a lacunar infarct. So you must know that active plaque of MS can also show restricted diffusion. Actually, some of the studies in literature, they actually told us that DWI should be routinely used. They suggested that DWI should be routinely used to pick up active plaques, but all of people do not agree with this. And in clinical practice, please remember, still our criteria is enhancement. It is not restriction. What I'm telling you now is key concept for your exam. How do you diagnose MS? And please remember the basics. If you are a neurologist, one of the basic things to remember is that MS is a multifocal, multiphasic illness. And so it will occur, if the symptoms, they occur again, only then can you diagnose MS. Classically in neurology, if a patient presents to you with neurology, you cannot diagnose that the patient has got multiple sclerosis. Time tells us. You send the patient back home. If the patient presents back after 6 months, 1 year, 10 years, then you say, okay, now this is the second phase, so I will label it as MS. So with that background, in the year 2000, a criteria was developed, and the neurologist who was heading this team his name was McDonald. So we call it the McDonald criteria. McDonald is no more with us now. So in 2005 and 2010, then this criteria was modified. And now we use the word International Panel or IP criteria. Key thing to remember is that there have been changes in 2017, and this has placed MR more prominently in the role of diagnosis of MS. And this can be potential, questions for your in your FRCR exam. So the revised McDonald criteria of 2017 tells us, this is the key slide for you to remember, that when you diagnose MS, there should be the criteria of dissemination in space and dissemination in time should be met. And as far as dissemination in space is concerned, you should have T2 hyperintense lesions in at least 2 of the following, 1 or more than 1. What are the 2 sites? So periventricular region, cortical. So I'll come back to this point, cortex. Juxtacortical means subcortical. Infratentorial means somewhere in the midbrain, in the brainstem or the cerebellum, and spinal cord. This is very interesting. Cortical. So people don't realize that, it's a white matter disease, but please remember it also can involve the gray matter. So now involvement of cortex has been given, has been included in the criteria, and this only happened in 2017. So these are the 5 lesions. But this concept is an exam concept. Dissemination in time. Please remember, multiphasic. Can we on the first presentation confirm using MR that it is a multiphasic illness? Yes is the answer. And what you can do is you can give contrast to the patient. If some of the lesions they enhance and others do not enhance, what does it tell us? It tells us that the lesions which are enhancing are of different age, they are active. And the lesions which are not enhancing are older, so they are inactive. So this is the use of contrast. Another criteria, of course, is to do a follow-up scan. Follow-up scan in which a new T2 lesion, you will say that it is a new lesion. So, but using contrast, you can diagnose MS on the first presentation, and that is a potential viva scenario. So, candidate 1, this is your case. This patient, his first presentation, they were suspected about demyelination. Over to you. Let me tell you the sequence is flare, 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 DWI, DWI. I have not given you ADC, non-enhanced T1, non-enhanced T1, contrast enhanced T1, contrast enhanced, flare, flare. Yes, please.
Okay, so on the flare sequence, I can see periventricular foci of high signal bilaterally. I can also see more confluent areas on the third image on the top row, which demonstrate restricted diffusion. Having a look at the sagittal images, that does appear to have involvement of the septocallosal area. I'm trying to see if there's any
enhancement. Look at this, this, and this. Any enhancement?
I can't see any areas of definite enhancement, no.
Okay, maybe you cannot see it because it is very small image, right? Do you see this enhancement here? Do you see this thing?
Yeah.
So actually there is enhancement, and it is, do you see this enhancement?
Yeah.
So, and this was, some of these areas are also, so for example, if you tally this with this, there is a bit of restriction also. So the point is that, can this be MS? Can you diagnose it as MS? Confirm it. First presentation.
I don't think there's enough information. We have got some periventricular lesions, but there isn't any, I can't see any cortical lesions or infratentorial lesions. And if we don't have any previous imaging for comparison, I think it wouldn't be enough to diagnose MS, so probably need further imaging to evaluate and to see if there's any new matter changes.
Okay. We can diagnose this as MS. Let me repeat what I told you. The point is that what is the definition? At least 2 of the following 5. You don't have to have lesions in all of them. At least 2, and the criteria is met. Periventricular is one criteria, just cortical is one criteria. And how many lesions? More than one, at least one or more than one. So in this particular case, you can see so many, you don't have to count them. You know, they are definitely, some of them is periventricular. And then there are subcortical here. So the criteria is met. Is met, dissemination space. And look, here is also met. Why it is met? Because this plaque here is enhancing. This plaque here is enhancing. Rest of the plaques are not enhancing, telling you that this is, these are active plaques, rest of the ones are inactive. So please remember, MS is a clinical diagnosis. So they will tell you, we are worried about MS because of this symptom, that symptom. So you already know they are suspicious. And super added to that, you get this kind of radiological features. And the bottom line is that by the revised 2017 criteria, you can diagnose it on the first scan, as in this case. Okay, thank you very much, candidate 1. We will go to candidate 2 now.
Hello.
Okay, you are with us. You can listen to me.
Yeah, I'm here now. Yeah.
Okay.
Sorry, I took a while to the button didn't come up.
Don't worry. Don't worry. So.
Cord, and there's also lesions within the pons, so we could diagnose on dissemination in space.
Excellent. So this case of MS has got, and this can start. Please remember that 10% of patients of MS present with cord lesions, and it is taken as a bad prognostic sign. In the exam, when you see something in the spine, always look at the brain. And if brain is not provided, you tell the examiner, I want to look at the brain. They want you to say that. Remember this. In this particular case, there are lesions there. So already we have got 2 out of the 5 are there, right? Dissemination space. And then you can ask for contrast. You can ask for rest of the features to diagnose MS. Yes, please.
Okay, so presented with multiple MRI sequences of a 27-year-old female with weakness 2 months. There is hyper intense signal on flare and T2 that crosses the midline in the splenium of the corpus callosum. On DWI B1000, there is a horseshoe restriction, and that's genuine when mapped with the ADC. And on the post-contrast enhancement series, this does show enhancement in horseshoe configuration. So this is consistent with an active kind of tumor-factive MS.
Okay, so what is your differential?
Differential for this that's crossing the midline would be a high-grade glioblastoma could present like this.
27-year-old, anything else in the differential in the tumor world? Can enhance, and they should be in the differential.
Okay, cool.
A younger patient, maybe before the GBM. So absolutely spot on. Now, the point is that tumor-factive MS is a type of MS presentation where there will be a large lesion and you will confuse it as a tumor. It can occur anywhere. But look at this case. In corpus callosum is involved. If you see, there is a rim of restricted diffusion. And classically, they say that active inflammation is towards the white matter. And towards the gray matter, which is this side, there will be less active inflammation. This DWI is quite impressive. This post-contrast is impressive, but not extremely, because a portion of this is also enhancing. Now, so this is tumor-effective MS. Nobody can diagnose tumor-effective MS just on the basis of a single image. You will consider things like lymphoma, etc. This is corpus callosum lesions in your book. And butterfly glioma and lymphoma are the top 2. I have already shown you this case previously. And this is what we call lymphoma, periventricular. I've not given you all the images, but just wanted to make the point that it is crossing the midline, and it is actually multifocal. Some rim enhancement, etc., is present. Yes, please. 2 years old, inability to walk 2 weeks after URTI. My history is too kind. The examiner is very kind to give you this elaborate history. So that's fine.
Okay, so my observations are that there is hyper-intense flare signal within the deep white matter, relatively symmetrical in distribution, and it's also within the medial aspect of the cerebellum. There is no contrast enhancement in this context in a young child that's got an URTI. I think this is likely to be ADEM.
Right. So, acute disseminated encephalomyelitis is a monophasic illness in which, as we discussed previously, the white matter abnormalities will be slightly larger or confluent as compared to punctate lesions, which are usually seen in MS. But MS can also present with larger lesions. One of the key exam point to remember is that other than white matter, at times, deep gray matter is also involved. So remember this. This is an exam point in ADEM. Not in each and every case, but sometimes it is. And this is what examiner is going to ask you. Look at the thalamus here. This is involved. Look at the basal ganglia, deep gray matter. Look at the dentate nucleus here, deep gray matter. So this, increases your confidence. Of course, this is a giveaway. Maybe the examiner will not tell you, or you might like to ask it. Please remember, in the real world, many of these patients, the history is too vague, and at times they just forget that they had something like this. Just to make a point that in ADEM, the lesions can be, larger. They can again show enhancement, which can be horseshoes shaped like this. Another case of ADEM, in which one can have a debate here that is it MS versus ADEM, and just on one study we might not be able to answer this question, but just wanted to show you restricted diffusion. Again, you will appreciate that the lesions are more confluent. Another one in which multiple lesions as well as cord lesions are, one can again have a debate here that this can be MS also. But in any case, let's crack on. Okay, now this patient is SLE. So you did a scan. And what are the findings? Is it MS, or you can explain it on some other grounds?
I don't think it's typical configuration or morphology with regards to the hyperintense signal, although it is predominantly periventricular. There's also basal ganglia involvement, and I wonder in the context of SLE whether this is a vasculitic picture, so more of a kind of small vessel disease pathology, or vasculitis.
Vasculitis. So remember that SLE, connective tissue disorder or vascular. Connective tissue disorder is one cause of vasculitis, and there are many others. A neurologist will always presents with MS-like symptoms. And if a patient has got vasculitis, this is the type of radiological features which you can get for ages.